Thanks, Nikhil, and congratulations for putting together this wonderful course. It looks really exciting and something very close to my heart as well. So I'll try to do justice to the new age optical biometers. And is my screen visible?
Yes.
Okay. So I think biometry has come a long way, and we started off by trying to predict IL power by measuring various dimensions of the eye and their interrelationships, and use this to determine. And there were the times when we used to do contact ultrasound, and Dr. Nitin will probably relate to what I'm saying. When we only used to have one type of A scan, there used to be a Humphreys A scan, which all of us used to have, and do our measurements, and then gradually we moved on to immersion and everything else. So I think today we've come a long way, and in fact, I will just talk about few of the prerequisites today that are there. I mean, we can go to any extent with what we can measure, but today we would want a good keratometry with the correct magnitude of astigmatism and the axis of astigmatism. We would look at the axial length. And typically, these were the two things we would be satisfied with, but today we can go on and on and on. So we could go to the AC depth, the lens thickness, the ELP, and the white to white, and of course, corneal thickness, and so many more things. But these are the basic, most important things that any optical biometer would be looking at. So currently, I think we've come a long way. We've come from the Javel shots, which I used to use, as a PG. We would do like maybe 100 odd Javel shots keratometries in one day for our biometries, and the Bosch and Lomb keratometer, which is again still there in many clinics. Coming to the contact biometers, then the the immersion, and then coming on to the optical biometers, where the IL Master 500, it was the first one, and it was there in almost every top surgeon's clinic. And today we've come to the swept source OCTs and the ray tracing mechanism. But what's most important, why we need to do all this? The applanation contact A scans would have a plus minus 0.24 mm range of error, which can give you a prediction of as much as a half to one diopter, depending on whether you're dealing with a myopic or a hypermetropic eye. The immersion scans got much better, and frankly, for the last 10-15 years, we've always mentioned that immersion A scans would be almost very close to optical biometers, but you can still see that there is a difference of almost 0.12 mm scope of error plus minus 1. Whereas optical biometers typically would have errors only of plus minus 0.01 mm. So you can see that there are magnitudes of difference between the three, and that's why it's so important today to move to an optical biometer, not just because of the axial length, because of the accuracy of measurement of all the parameters we spoke about, right from the corneal thickness to the keratometries to the axis to the AC depth, because all of them go into the modern formulas. It's not just the axial length which you can get from the A scan. So these are some of the currently available biometry devices, which you can see. It contains several of them. So there is not just Lenstar and IL Master. You will have so many. There is a nice one from Tomy, even the Pentacam AXL, Oculus, and the IL Master 700, which has become one of the best, optical biometers. And then, of course, the Antirion, which is now available from the Heidelberg. So when we compare partial coherence interferometry, which is the laser interferometry used in the IL Master 500. It basically uses a more basic form of a light source and a scanning slit, which is comparable to the Lenstar uses the OLCR, or the optical low coherence reflectometry, which provides axial measurements of the entire eye from the cornea to the retina. So seems to be much more accurate. And let's look at the advantages and disadvantages. So it tends to give you the true central corneal power, that's the OLCR, and measures 32 points in 2 circles and inner and outer diameters, and measures size and centricity of the pupil. However, it may have limitations because of low penetration in dense cataracts. And in posterior subcapsular cataracts, typically, the Lenstar, although with the newer nomogram, the newer style of measurement that it uses, it has improved a lot, but there can be a small limitation in few cataracts. And so we have worked with several of these machines. And the Pentacam AXL is another new kid on the block, which is combined stream flux tomography with axial length and total eye wavefront measurements, and then objective refraction and retroillumination. This is something which I haven't used, but it has several advantages. So the low and high order aberrations of the eye are measured as well. And the retroillumination technology for the preoperative assessment of the lens opacities and for the post-op IL position can be judged, but it does not measure the lens thickness or the pupil size, which can be a big drawback, and it's slow, and therefore there's scope for errors. So going on, I think if we choose the Lenstar to begin with, I have maximum experience with the Lenstar. So I've been working with it for more than 10-15 years. I have used the IL Master 700 for a while as well. But the Lenstar, we'll compare the two technologies. These are the two most popular biometers today, and they're the new ones as well. So it does all these measurements, as you can see, almost everything that you need, including the retinal thickness, which is very, very important because this is what differentiates it from the other newer OCTs as well. And the keratometry, I think, is best in class because it does a 32-point keratometry. If you compare it to the IOLMaster 500 or even to the 700 today, we'll do that later. It does 500 used to measure only 6 points. So there was a big difference between what the Lenstar was doing. However, today the 700 with very new features on keratometry has changed the game as well. So also, many of the new biometers come with these Placido clip-on devices or built-in devices. The Lenstar has the T-cone. The Tomy has a nice Placido as well. And today, the IOLMaster 700 tries to do something similar by interpolating data. So the Placido is useful when you want to do toric IOL planning, and also in clinics where you want to rule out corneas which may be suspect or keratoconus, so that you don't go wrong with when doing toric IOL. So I think it's important to have a Placido if possible on your biometer. If not, then you can have a standalone, but that will add to the cost. So all these formulas are available on the Lenstar, the Hill RBF, which only comes with the Lenstar, and it's one of the very good artificial intelligence formulas today. The Barrett's, which almost everybody relies on today, including the toric calculator and the TrueK for post-refractive eyes. And then, of course, all the other usual formulas are all there. So you have a choice to use that with the Lenstar at least, and with many other machines. So advantages, instead of slit imagery, which the 500 use, this uses optical biometry. So it's much more accurate for all the anterior chamber depth measurements as well, and the corneal thickness. And also it has a high density keratometry, so that makes the keratometry very robust for, especially for toric IOL planning. And also does several other functions, but some disadvantages that very dense cataracts, you may miss it. So typical penetration rate is about 94 to 95%. IOLMaster 700 now claims 99%, but that remains to be checked. So there was this new mode of on the Lenstar, which kind of concluded that the new measurement mode of the OLC system provides a significant increase in the number of eyes that can be measured. So it kind of comes pretty close to the 700 now. Then again, this benchmark study, which I think came out of Narayan Netralaya, which compared 4 biometers, and the dropouts for axial length measurement were significantly higher in the NIDEC AL scan and the Galilei G6 compared to the 700, but there was very good agreement between the 700 and the Lenstar LS900 for axial length and keratometry, which are probably the most important 2 parameters. So pretty comparable there. And then this another study, which basically was trying to again do the repeatability of different optical biometers, comparing the swept source. So again, agreement of the axial length, AC depth, and spherical equivalent between both the PCI and the swept source was excellent. And the OLCR was found to be pretty good. And there, we switch on to the swept source, which is typically the Tomy and the 700. Some new features there. So the principle is based on swept source technology, and that also has several other, very sharp features. The distance independent telekeratometry, and so the telecentric keratometry, which changes the game again. And then, of course, it does measure the posterior corneal surface, and therefore provides for the total K. And that total K can be used for the different formulas, especially the Barrett's total K formulas, which are good for post-refractive surgeries. So this is how the TK works, and you can see that it can be integrated into several of the formulas. And I will not go into details of how it works, but it basically allows you to customize the posterior corneal curvatures and feed them into the new formulas and use them. So it remains to be seen how effective it will be. So the Barrett's TK Universal 2 and the Barrett's TK Toric are being used by several users today. Barrett's, the IOLMaster 700 comes with all the formulas, the Barrett's suite, so it contains all the newer formulas, and including the TK formula, which is only on the 700. And it does give you the retina fixation check for the fovea. So it has several frills to it. And these also would be kept in mind when you're trying to decide which optical new biometers you might want to invest in. So it has great keratometry. It has great penetration of the dense cataracts, and also the fixation check. Recently introduced is the central topography. Nikhil, feel free to just warn me like 30 seconds before you want me to finish. Okay, so then I'll just close it out. Yeah. So the new formula, the new thing on the 700 is the central topography, and this has been derived from fewer points. So the difference between the Lenstar and the IOLMaster 700 topography is basically that the Lenstar uses a Placido, whereas the 700 uses basically 19 points, which are from the cornea. So Lenstar typically is using almost 8,000 points. So I feel that I've used both. I mean, I've seen the Lenstar T-cone and I've seen a little bit of the topography. I feel that on this aspect, the Lenstar scores over the 700, while on many others, the 700 scores over it. So the topography on the Lenstar will be way better than what you can get on the 700. And so several advantages there. I think it can go through posterior subcapsular cataracts, which are more close to the nodal point of the lens, and tilt and decentration of the lens can be detected. And it also comes integrated with the Callisto and the microscope, so you can have total markerless surgery, and it really makes a lot of difference to your integration of surgeries when you're doing toric IOLs. So only disadvantage to me would be that the cost of the 700, which is quite exorbitant, almost twice of what other biometers cost, and the Barrett's TK still remains to be seen whether it still gives you good outcomes. So going on, I think. I'll go on to the Tomy, which also is a swept source, pretty good. It also comes with a Placido, does all the routine things, and gets all through all the dense cataracts, does good planning for toric IOLs, and is pretty good as well. And going to the last one, few slides on the Antirion, because I have to finish. Antirion comes with, this is the new kid on the block, almost again, another 20 lakhs more expensive than the other machine, but it comes with lots of other things that you can do, the imaging app, the cornea app, the metrics app, and the cataract app. And it has several advantages. Yeah, I'll finish in 10 seconds. So it gives you the corneal wavefront analysis and also gives you the corneal maps, including the anterior chamber angle. And it gives you the topography, the epithelial thickness mapping. It gives you almost all that you need and way beyond, and gives you all the aberrations as well. So I think going on, we've come a long way. And the take-home message is that optical biometry, I think, has come a long way. We still talk about whether to take an optical biometer. The option should be which optical biometer to take. There are so many choices today. Over 95% eyes can be measured even with very dense cataracts. And IOL formulas keep getting better and better. And over 90% outcomes within plus minus 0.5 using newer formulas like the Hill RBF3 and the Barrett's. And all-in-one devices are making life much easier with never before accuracy. However, cost remains a big factor because all these machines are very expensive, and patients might expect great quality without actually having to pay for what they don't know what goes behind it. I think ray tracing holds great promise. It'll overcome all the formulas as well once it comes of age. So with that, I think I'll stop here, and thanks Nikhil and Nitin sir for allowing me to speak in this course. I hope I was able to make a little bit of sense.
Thank you so much, sir. That was such a wonderful